Good evening. I'm psychiatrist Jay Pfoffer, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call here in the Fort Wayne area by dialing 969-2720, or if you're calling any place coast to coast, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, I am broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's mattersofthemind at WFWA.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Pfoffer, I have suddenly had an increase of dreams while I'm sleeping, usually multiple dreams in one night. I don't have any new medications. Is this a symptom of a bigger problem? I would say not necessarily, based on the nature of the dreams. If the nature of the dreams are not threatening or persecutory, you probably would be okay. Now, people will often dream more, especially when they're not getting enough sleep. So they're more tired. They might dream more then. Sometimes people will dream more when they're under more stress. A component of clinical depression can be that you dream more. And one of the advantages of the medications used for depression 40 years ago was that they would suppress dreams. So if you're having nightmares, if you're having scary dreams, if you're having dreams that awaken you in the middle of the night, and your heart's pumping and you're sweaty and it's frightening, that could be a bigger issue. But I would say that dreaming overall is a pretty good thing. Dreaming helps your brain kind of recharge. Dreaming helps this part of the brain over here, which is the hippocampus part of the brain. It helps with your memory center, because when you're dreaming, the front part of your brain, the thinking part of your brain, shuts down. So when the thinking part of the brain shuts down, it causes you to necessarily lose judgment, and you will have very abstract dreams. That's why a lot of dreams won't make sense to you unless you really think through them. Many dreams will represent things you're going through in a very symbolic way over the past 24 to 48 hours. And the later in the night you dream, the more recently those events are generally occurring. And the dreams that occur shortly before waking up, many times will be even more meaningful to you about what's happening over the past day or so. And it can be a little bit of an insight into what's going on in your life and what's concerning you, what's bothering you. But you have to think very symbolically, very abstractly. Dreams typically don't mean precisely what you're able to recall. And if you don't try to think about your dreams immediately, it's like the old blackboards where the dreams are erased very, very quickly. Your brain's very good at erasing dreams unless you write them down, unless you start talking about them, unless you think through them first thing in the morning. But you're right, Keith, when you first start talking about dreams increasing, you can often notice that you're changing medication, or you have some kind of other condition going on. But if you haven't changed medication recently, the dreams are probably somewhat benign, with the exception of maybe you getting more sleep. When you need more sleep, you'll often have more deep sleep, where you're very deep into sleep. The brain waves are very high and low, and they're very wide apart. And you, if awakened during a deep sleep, you'll be very confused for a few seconds, and then you come out of it. With dream sleep, same type of thing. Often it's called sleep deprivation, where people haven't gotten enough sleep. They'll notice they're dreaming more. So that can be a factor. Thanks for your email. Let's go to our first caller. Hello, Keith. Welcome to Matters of the Mind. Keith, you had mentioned that you recently started a new medication for your anxiety, but you don't feel a difference yet. Does it take a while to build up, or should you contact your doctor? I would say, Keith, it depends on the nature of your anxiety and depends on the nature of the medication. For instance, if you're taking medication for anxiety that's related to worry and just ruminating about things and dwelling on things, those type of medications used for that matter, such as buspirone and the so-called SSRIs, the selective serotonin reuptake inhibitors, they do take 3 or 4 or 5 weeks to gradually help you with the worry and rumination. But if you're taking medication for panic, where you're having blasts of anxiety, where you have an increased heart rate, you're shaky, you're having diarrhea, nausea, feel like you're going to die, your head's spinning, those types of episodes of panic are often treated with benzodiazepines such as Xanax, Klonopin, Ativan, which typically work very fast. And we often use the anti-epileptic medications in a similar manner, such as gabapentin or pregabalin, as a means of quickly relieving the panic attacks. Hydroxyzine is an antihistamine that sometimes can be used for a similar type of situation. So it depends on the nature of the anxiety that's being treated, the type of medication that's being used. But I often mention to people, Keith, when I hear about somebody having blasts of panic, I often wonder, are there other things going on? For instance, if you have a blast of panic where you're having a really fast heart rate, that could be from, especially for women, postural orthostatic tachycardia syndrome, also known as POTS. That can give you an increased heart rate. Women are 8 times more likely to have that than men. You can have a cardiac arrhythmia where you have a fast heart rate called paroxysmal atrial tachycardia. It's where your heart just starts pounding really, really fast, sometimes going up to 180 beats per minute really, really quickly. You can have a pulmonary embolism where you have a blood clot in the lung. That will give you horrific anxiety. And people who have high thyroid, if your thyroid is elevated because you recently maybe changed your thyroid dosage, that can give you a lot of anxiety. So I'm often looking for the underlying reasons for anxiety. There are a lot of medications that can treat the symptoms of anxiety, but we often have to look out for the underlying causes, especially if they're coming across as panic. Keith, thanks for your call. Let's go to our next caller. Hello, Chanel. Welcome to Matters of the Mind. Chanel, you had mentioned that you don't have an appetite when you're under stress, and should you be concerned? Chanel, when people get under stress, what happens is adrenaline goes up. Now, a chemical cousin of adrenaline is norepinephrine. When adrenaline or norepinephrine go up, you notice a few things. You might notice that your mouth is drier. You might notice that during that time you get a little bit of constipation perhaps. You get kind of dry eyes. But with that norepinephrine going up, you will notice not uncommonly that you're going to be sharper with your thinking, because when norepinephrine goes up, it will fire up the front part of the brain, which is the thinking part of the brain. That's the part of the brain I mentioned earlier that shuts down when you're dreaming. But when you're really focusing and concentrating, norepinephrine goes up. When you get under a lot of stress and your anxiety level goes sky high, the little amygdala down here, which is the anxiety, fear, and anger center of the brain, that really gets fired up. And sometimes that will cause the front part of the brain to sometimes overreact and cause people to ruminate about things. If you have a lot of norepinephrine, if you get under a lot of stress sometimes, it will decrease the stomach motility. Some people get constipated when they're under stress, and for those people, they might notice they're just not hungry. So lack of appetite can be a symptom of excessive stress. What makes that worse for some people? Well, if they drink a lot of coffee, caffeine will actually give you a decrease in appetite. And for some people, if they consume a lot of coffee with caffeine, that can be particularly problematic for them during that time. Tea is not so bad in that regard. Tea has a chemical in it that actually will decrease anxiety while at the same time give you a little bit of an energizing effect. And that's why L-theanine, which is the active ingredient in green tea especially, can be a nice chemical for anxiety for some people. So tea will be less prone to creating decreased appetite or increase in blood pressure compared to the caffeinated coffee that many people will drink. Chanel, thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Fulver, I just started taking antidepressants, and I've noticed that I've lost my appetite. Another person lost their appetite there. Am I on the wrong medication, or do I need to just get used to it? A lot of antidepressant medications will actually increase the appetite. If you lose your appetite, it does not mean that you're necessarily on the wrong medication. Now, when I think about the traditional antidepressant medications that affect the appetite one way or another, we're talking about medications that increase norepinephrine, dopamine, and or serotonin. Those are that's a trilogy of the neurotransmitters that we've been discussing for the past 60 years. If you increase serotonin, you bet, sometimes that will decrease the appetite. It was first noticed back in 1987 when this medication called fluoxetine, also known as Prozac, came out. When Prozac came out, a lot of people had a decreased appetite, and people looked at that favorably, especially people who were prone to binge eating when they got under a lot of stress. So the serotonin medications can decrease your appetite, sometimes as a side effect, sometimes as a favorable effect for people who are binge eating while they're depressed. I mentioned earlier norepinephrine. Norepinephrine is kind of like a byproduct of adrenaline. Norepinephrine and dopamine kind of run in tandem. in the sense that they can both be alerting, they can help with concentration, they can help with motivation, but they both can decrease the appetite. That's why stimulant medications, which do increase dopamine and norepinephrine, as a side effect can sometimes decrease the appetite unfavorably, especially for younger people. So the medications that are used as stimulants, such as the Ritalin products, the amphetamine products, they're increasing dopamine and norepinephrine, and they can sometimes decrease the appetite. Of the antidepressants that specifically increase dopamine and norepinephrine, and we're talking more about bupropion or Wellbutrin. And there's a newer medication available now called Auvelity. Auvelity has bupropion in it, but it also has dextromethorphan in it. Dextromethorphan is an old cough medicine that's been around for 65 years, but if you have really high levels of dextromethorphan, that can help with depression by affecting another chemical called glutamate. But bupropion is in Auvelity, and for some people, they'll have a decreased appetite with that too. So yes, it can be related as a side effect with your medication, but the bottom line is, if you're having a decreased appetite, you have to weigh the pros and the cons of, do I want to stay on this medication or not? If it's intolerably decreased with your appetite, you may want to look for another medication at that point, but you have to weigh the pros and cons of any medication and its side effects and determine, are you willing to stick with it for a while? Because with some medications, by all means, some medications, you'll notice that the side effects will diminish over the course of time. And obviously, as clinicians, we can always adjust the dosages. For many people, we'll try to have them maybe take a lower dosage of medication because genetically, they might be a slow metabolizer. Slow metabolizers to different medication might have 5 times the blood levels of an extensive or a normal metabolizer. So if you're a slow metabolizer on a medication, it might just mean that you need a lower dosage. It could be a good medication for you, but you just need a lower dosage. Thanks for your email. Let's go to the next caller. Hello, Ken. Welcome to Matters of Mind. Ken, you want to know about the pros and cons of ketamine and S-ketamine, Spravato, which is a nasal spray. Ketamine came out in 1970. It was actually created by an organic chemist up in Wayne State University back in the 1960s, and it became approved as an anesthetic in 1970. So ketamine's been around a long time for anesthesia. Ketamine was used off-label or without approval for the FDA, off-label for depression about 20 years ago, and it has been used in that way since. Ketamine is a medication that will affect glutamate. Now, I mentioned earlier the trilogy of norepinephrine, serotonin, and dopamine. They have been studied for the past 60 years. We've been treating people with those type of medications for the past 60 years. And now we're talking more about glutamate. Glutamate lives in the gray matter or the outside part of the brain. Glutamate is the accelerator, GABA is the brakes. So you've got the accelerator, glutamate, and you've got GABA, the brakes. So what we're trying to do now when we treat people with depression with ketamine and its left-sided piece, S-ketamine, which is Spravato, what we're trying to do is fire up the glutamate in the outside part of the brain. So it's like pushing on the accelerator on the car, and it's opposed by this other chemical by the name of GABA, which is like the brakes. So where does norepinephrine, dopamine, and serotonin fit in? They come from the brain stem. The brain is kind of shaped like a cauliflower, and you got the stem of the brain. That's where norepinephrine and serotonin and dopamine reside. They will project to the gray matter of the brain and basically work in consultant roles with glutamate and GABA. So when you think about glutamate being the accelerator, GABA being the brakes, serotonin, norepinephrine, and dopamine, they're kind of in the passenger seat giving advice on if the glutamate should push on the accelerator more or if the GABA should push on the brakes more. And I always remind people that talk therapy still has its role when we treat people with mood disturbances. Talk therapy helps you steer the wheel, so it's helping you actually get to where you want to go. But glutamate's the accelerator, GABA is the brakes, and that's where ketamine and S-ketamine are working. Now, what are the drawbacks of those treatments? Usually, with all medications, you can always have side effects. During the treatment themselves, you can have an increase in blood pressure for about 40 minutes during the treatment within the 2 hours of each treatment for ketamine or S-ketamine. So we do monitor blood pressure for people. You can't have a history of any bleeding or any difficulty with weak blood vessels in the brain because like with exercise, which could increase the blood pressure while you're exercising, using ketamine or S-ketamine can do the same during the treatment itself. But at the end of the 2 hours of monitoring for ketamine or S-ketamine, you can typically leave with your blood pressure being normalized thereafter. That's the biggest drawback. When you have side effects from ketamine and S-ketamine, typically it's very time limited, usually within that same day, such that day by day, you're not noticing those side effects. The nice thing about ketamine and esketamine, since they're directly working on the accelerator of the brain, the glutamate, they are working very fast. So many people will get a very quick response, unlike these medications that affect serotonin, dopamine, and norepinephrine, where it might take them weeks to give effects, because remember, they're coming from the brainstem. They're giving advice to the glutamate and GABA in the outside part of the brain, and in doing so, they need to make some protein changes at the receptor level, and that might take 6 or 8 weeks for a lot of people. So we've gotten used to waiting 6 or 8 weeks for the past several decades for our antidepressants to work. Now that we have ketamine and esketamine, we are noticing that we're getting really fast results within a matter of hours for a lot of people with the depression. Ken, thanks for your call. Let's go to our next caller. Hello, Joe. Welcome to Matters of the Mind.
Hello. How are you doing?
Joe. I'm doing okay. Thanks.
Hey, so good to talk to you. I am all about these new studies about the pineal gland.
Yeah.
And there's 2 crystals in there. First off, what are the size of them? Are they the size of like pieces of rice? You know, a particle of a piece of rice? How big are the crystals in the pineal gland?
It's right there, right smack in the middle, about the size of a small pea. That's how large it is. It kind of hangs down there. It's kind of in the middle there. The pineal gland is about the size of a pea, and it's just above the pituitary gland. And a little bit better look, it's right about there. And basically, the pineal gland will be a little gland that has a tremendous amount of sensitivity to light. So in the winter time, when it's darker, there's less light hitting the retinae, and with less light hitting the retinae, you'll have less of a signal going to the pineal gland. With less of a signal going to the pineal gland, you'll have an increased amount of melatonin. Melatonin is sometimes referred to as the vampire hormone because it rises when it gets dark. So it's thought that when people have a tendency toward winter depression, they're particularly sensitive to the darkness, and they have more winter depression because they get more melatonin, presumably during the daytime and unnecessarily, and they feel tired. They don't want to be around people. They get more depressed. They get more fatigued. They have poor concentration, and they want to hibernate. And that's from a biological standpoint. It has a role in hibernation for mammals.
How interesting.
Yeah, you're right, Joe. There's going to be a lot more studies about it. I remember hearing for the first time about seasonal affective disorder, which is now called winter depression, not uncommonly. But I first heard about it in the late 1980s, and I thought it was pretty interesting because if you stimulate the eyes with bright light in the wintertime, we call it light therapy. It's where you sit a foot or two away from a really bright light. And you sit there for about 20 or 30 minutes first thing in the morning from about November through March. And you do it every morning, first thing in the morning. Basically, what you're doing there is you're shutting down the pineal gland so it's not secreting as much melatonin. And in doing so, it treats depression. And for many people, they've had dramatic relief from that. And I often refer to a light therapy for somebody who has winter depression, as well as making sure their vitamin D levels, at least 55 or more. Vitamin D levels, especially for those of us up here in northeastern Indiana, not uncommonly will slip down the single digits in the wintertime. So I always want people to get their vitamin D level up in the wintertime because vitamin D also is manufactured in the skin upon exposure to ultraviolet sunlight. So with vitamin D, it's the ultraviolet sunlight that stimulates the vitamin D production. With winter depression, it's actually the intensity of the light. And the bright light that we're talking about is the light intensity during the summertime at about 10 a.m. So that's kind of the light intensity we're talking about. So some people, if you can get out at 11 a.m. or so, or noon, the sun's up, it's a bright sunny day. If you can get outside and go for a walk for 20 minutes, that'll help. Not only will you be getting some fresh air and some exercise, but you'll also be getting exposure to light. But that all comes back to that little small pea-sized pineal gland.
Can I ask another question
Go ahead, Joe.
The crystals? If you put the crystals under pressure, do they make a radio frequency?
Beats me. I don't think we're advanced to really know that so far in terms of knowing how to really deal with the crystals right now and what impact that might have. So to know, Joe.
Well, thank you so much for everything that you're doing. And I love that I'm able to ask you about the pineal gland. It's such a big part of our everyday observance of reality. I appreciate everything you're doing.
Thank you, Joe.
So much.
All righty. Have a good night. Let's go to the next caller. Hello, Amy. Welcome to Matters of Mind. Amy, you want to know about the signs of a borderline personality disorder. Borderline personality disorder, Amy, is generally related to having difficulty with attachment to a parent, typically the mother, at a young age. We're talking about prior to the age of 4 years old. So it's very important from early infancy to those early toddler years and even before you go to school that you have a really close attachment to a parental figure, and it can be a mother, sometimes it's a grandparent, but typically it's a mother. And if you don't have that attachment, because the mother or father, if he's the primary caregiver, if they have some issues of their own where they're not really able to attach, people can have borderline personality disorder where they have moodiness, they can have a sense of abandonment depression, where when they feel abandoned, they get horrifically depressed and anxious and panicky. When people have borderline personality disorder, they can often have a sense of rage, they can have a quick temper, and they can have a sense of emptiness, feeling like the whole life is just empty, and they'll often have ongoing suicidal thoughts. They just wonder, why are they still here? And many people with borderline personality disorder will get so depressed that they will make suicide attempts. Sometimes they'll cut it themselves as a means of just releasing some natural opiates in the skin. They don't realize they're doing that, but when they cut it themselves, they actually have a soothing effect. But they do that when they get under stress, and it's a way of releasing endogenous or natural opiates. You release natural opiates to your brain and you get a calming effect. That's why people do it. They don't realize they're doing it for that reason, but they'll cut it themselves when they get under a lot of stress. That goes along with borderline personality disorder. People with borderline personality disorder will often look at the world around them as being all good or all bad, all right or all wrong. They don't see the gray areas in things. So they often will have difficulty with interpersonal relationships, have a hard time holding on to relationships because they can feel highly attached. And they have this phenomenon called chameleon personality, where they lack identity. They would start to take on the identities and the personalities of people around them in social environments. So they have a difficult sense of their own identity. So the best way of treating them will often be through therapy. We'll give them medication sometimes for depression, and if they have severe moodiness, and if they get stressed out so much that they get into a psychotic episode, sure, we'll give them antipsychotics sometimes, but more often than not, borderline personality disorder can be best treated with talk therapy to help people gain an awareness of how they can better cope with situations that they're enduring. Dialectical behavioral therapy, DBT, is a means specifically that will often address borderline personality disorder. And people will have different degrees of it. Some people will have borderline personality disorder to such a degree that they can't function in society. Other people will be more mild, where it'll be noticeable, and it's something that can be addressed with individual therapy. Thanks for your call. Let's go to our next caller. Hello, Casey. Welcome to Matters of the Mind. Casey, you wondered if you're able to check a relative into a facility if you feel they are not stable. You have to have a doctor's order to be able to have somebody involuntarily committed to a psychiatric facility, if that's what you're asking, Casey. So a family member can contact a doctor and say, here's my concerns, here's the issues, and the doctor will typically evaluate a person over the course of 3 days in a hospital environment to determine if they need to have ongoing treatment involuntarily, or many times if people acknowledge that they have difficulty as patients, they'll come into the hospital within those 3 days. They will say, yep, I understand why I need to be here. They sign involuntarily and they get the adequate treatment at that time. But you're not able to check a relative into a psychiatric hospital, even though they might be doing that on movies sometimes. You always have to have a doctor be able to give the okay. And again, it's not going to be something where somebody goes into a psychiatric hospital for months and months if a relative checks them in. The clinicians in the hospital have to agree that, yeah, they need to be there for a serious reason. Casey, thanks for your call. And we got about a minute and a half here. Let's go to our last email. Let me see if I can answer my last email here very quickly. Dear Dr. Faber, are there changes in the brain that occur when people lie? Are lie detector tests valid? Can someone become a good liar? Well, good question. What happens in the brain when somebody lies is generally this little amygdala, to which I referred earlier, really lights up. That's your anxiety center of the brain. That's the guilt center of the brain, the anger center of the brain, that really lights up when you're lying. The front part of the brain when somebody is lying is actually working harder. So they have to think about their lying. And a polygraph test is not often valid because some people are good liars. And the more you lie, the more the brain changes to adapt to making you believe the lie itself. So the lie detector test, which is checking blood pressure, heart rate, perspiration, tensing up of the body, they can't be valid during that time because some people are really good at lying and they can make themselves believe what they're actually saying. Thanks for your email. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm psychiatrist Jay Falver, and you've been watching Matters of the Mind, which is now available on YouTube. God willing and PBS willing, I'll be available next week. Take care. Good night.